सुने कि सुनेन यार सोध्नु पर्यो नि सोध्नमा can you see the screen भनेर
Can you see the screen?
Yes, sir.
Yes, sir.
Okay. Can you see the slide?
Yes, sir.
Yes, sir.
Okay. Everybody can see the slide now?
Yes, sir.
Okay.
Yes, sir.
So, wound infection has always been a major complication of surgery and trauma. I'll be talking about the definition of wound infection in the subsequent slide. And wound infection has been documented for, say, 4,000, 5,000 years. And the Egyptians, they knew about wound infection and they prevented putrefaction of mummification. So you can see the mummies, even after thousands of years, they're still preserved. And the Assyrians, they knew about prophylaxis. That means they knew that there were certain elements which caused antisepsis or they prevented infection. Hippocrates also taught about antimicrobials. What is antimicrobials were? Wine and vinegar. Vinegar, interestingly, is still used in the surgical wards. So if a patient or if somebody has Pseudomonas infection, we use vinegar dressing. Interesting. Can you hear me?
Yes, sir.
Okay. The Romans also knew that if pus formed in the human body, it had to be drained. It needed to be drained. So that is the basic principle of pus. Whenever it forms in the human body, you have to drain it. Well, I think you're all familiar with Koch's postulates. It says that it must be found in considerable numbers in the septic focus. Now here it represents to the organisms, and it should be possible to culture it in a pure form from that septic focus. It should also be able to produce similar lesions injected into another host. So here it represents the organism. So Cox made some of the postulates and they were pretty accurate. Interestingly, there was an Austrian obstetrician, Ignaz Semmelweis, who showed that simple hand washing reduced the infection rate in the obstetric ward. So his infection rate came down from 10% to 2%. So he said that if you can do a thorough hand washing between procedures, you can safely reduce the infection rate, which has been a very similar scenario nowadays. So if you wash your hands a lot, maybe the coronavirus will be eliminated from your hands. And then there was the discovery of sulfonamide.
Sir, slide change भइरहेको छैन अहिले
के चेन्ज भएको छैन
स्लाइडहरू फर्स्ट स्लाइडमै छ अझै नै
हो र
हजुर
स्लाइड चेन्ज ह्याङ अन द एन्ड के भयो आज ओके अहिले Are you there?
चेन्ज भएको छैन सर अझै नै
स्लाइड चेन्ज भएको छैन अरे
हजुर
अहिले
भएको छैन अझै नै
छैन के भयो आज Just a minute, है
हस्
We're still in the first slide or what?
यस सर
अहिले
भएको छैन सर
के भयो ह्याङ भयो अनि के भयो चेन्ज हुनुपर्ने एकछिन है ह्याङ भयो जस्तो छ
Well,
देखिन्छ स्लाइड
which was slide 3?
चेन्ज भयो अब त्यहाँ
2.
2 मा हो अहिले देखिन्छ
हजुर अहिले चेन्ज भयो 2 मा पुग्यो
ओके Can you see the slide?
यस सर
Is it changing?
यस सर
Okay. So sorry about that. So we just talked about the Cox postulates, and then the concept of sulfonamide. That was a magic bullet. Zober Kugel, he says that sulfonamide was a big invention. So after the invention of sulfonamide, people were very happy because the whole concept of sulfonamide was it kills the microbes but not the host. So they were very happy. So sulfonamide made a very big discovery, and it was the drug of choice for so many number of years. But unfortunately, nowadays we do not use too much sulfonamide because there are a lot of sensitivities. And then Louis Pasteur and Alexander Fleming also contributed to this field. Slide change, Baba.
भएको छैन सर
होइन
सर सेकेन्डमै छ
सेकेन्डमै छ Okay, now
अहिले
अझै
पनि
नै
सेकेन्डमै छ सर सर हाम्रो क्लास पनि रेकर्ड गर्नुपर्ने त्यो पनि भइरहेको छैन
रेकर्ड हुनुपर्ने त्यो त उहाँ कलेजबाट
होइन सर यहीबाट हुन्थ्यो
स्लाइड चेन्ज भएन
छैन सर
सर त्यो
Enter मात्र गर्नु न यस्तो त गर्यो भने भइहाल्छ
अहिले
It's going.
भएको छैन भएको छैन सर अहिले
सर
भयो
माउस युज गरेर स्लाइड चेन्ज गर्नु न
त्यही गरे माउस युज गरे हो भएन यहाँ
हुन्छ
भयो सर अब भयो भयो सर
तिनमा
अहिले
भयो सर अहिले
यसरी नै धर्नु न
Okay, is this fine? I've got slides on the sides.
हुन्छ सर त्यही स्लाइडबाटै त्यसरी
Yeah, okay. So this is, I think, slide number 3. Okay. देखिन्छ अहिले Hello?
देखेको छ सर
Most staphylococci that are prevalent in the wards are now resistant to penicillin. So penicillin was a wonder drug once upon a time. During the World War, they discovered penicillin, and it was given to, I think, the first was given to a policeman. Later on, he had developed recurrent infection, and then they ran out of penicillin, and that was the story of penicillin. Nowadays, we don't use penicillin too much, although it is a drug of choice in, venereal diseases and STDs, sexually transmitted diseases, and also heart diseases. Otherwise, the scope of penicillin is now going down. And many bacteria develop resistance through the acquisition of B lactamases. Now, in our wards, we see a lot of these things, right? The main concern is the resistance of bacteria to antibiotics like methicillin-resistant Staphylococcus aureus, MRSA, and vancomycin-resistant Enterococci VRE. So when nowadays people are empirically using antibiotics for any Tom, Dick, and Harry cases, and we have a lot of development of resistance. So whenever you prescribe antibiotics, it has to be rational and it has to be empirical. All right. So over treatment with broad spectrum antibiotics is not recommended. Slide changing?
यस सर
Huh? भइरहेछ है? Advances in control of infection in
यस सर
Okay, thank you. So aseptic techniques has now replaced the toxic antiseptic techniques. To make it very simple, aseptic techniques means any technique that is free of organisms and its spores. Antiseptic, on the other hand, may not be free of all the organisms and spores. So one is relative, the other is absolute. So nowadays, the absolute technique of aseptic techniques has replaced the toxic antiseptic techniques. So the advances in control of infection in surgery is coming down. And now the development of newer antibiotics and wide spectrum antibiotics, they have transformed the infection rates. So you have, I don't know, so many different types of antibiotics now that the infection rates are easily controlled now. And one of the interesting things about infection control is if you do a delayed closure, it remains useful in contaminated wounds. Now, you may not be able to clearly identify this point. Delayed closure means when somebody sustains injury, all right? And say somebody has a road traffic accident and lands up in the emergency after 6 hours, and the wound is very bad. The doctor on duty will refuse to put stitches over the wound because 6 hours is a crucial time. So any injury, if some patients sustain any form of injury, the wound has to be stitched within 6 hours. After 6 hours, the chances of getting infection is very high. So what you do is you simply clean the wound, you debride the wound, you stop the bleeding and do subsequent dressings in the next few days. And once the tissues granulate, you can put delayed sutures or secondary sutures. So after 6 hours, it is known as secondary sutures. Within 6 hours, it is known as primary sutures. Is that clear? Can you see the slide?
Yes, sir.
Now, physiology, let's talk something about the physiology. What is the protective mechanism from bacterial infection in the human body? Well, number one is intact epithelial surfaces. So, as long as the surface is intact, you cannot expect the bacteria to gain, you cannot expect a huge number of bacteria to gain entry into the intact epithelial surfaces. The skin is the largest or the biggest viscera in the human body, and it is the best antiseptic viscera. Means the skin has a lot of protective phenomenon. If your body did not have skin, you would be vulnerable to a lot of infection and you would succumb to those injuries and infection. So intact epithelial surface is very important. Chemical. There's low gastric pH. Anybody know gastric pH of the stomach? Rashi? Can you anybody hear me? Anybody?
1.5 to 3.5.
All right. Anybody else?
Sir, one.
Okay. You're okay. You're almost correct. 0.9 to 1.5. Okay. That's the range. So the contents in the stomach is very, very acidic. It's like a concentrated hydrochloric acid inside your stomach. So even the cheekbones that you swallow and the fish bones that you swallow will dissolve in seconds inside the stomach because the acidic pH is so high. The other protective phenomenon are humoral. There are a lot of antibodies in your body, IgG, IgA, IgM, IgD, IgE, and then the complement system and the opsonins, all right? And cellular, well, your body has a lot of phagocytic cells, macrophages, and then you have polymorphonuclear cells and killer lymphocytes which fight against the invading organisms. So all these mechanisms, they're compromised by surgical intervention and treatment. So if somebody is going through surgery, then this system will be somewhat compromised and you have problems. Oh, the patient may be vulnerable to infection. Causes of reduced resistance to infection. All right. How do we have reduction to infection? Metabolic causes. Any patient who is malnutrited, or any diabetic patient, any patient with uremia, or any patient having jaundice, they have reduced resistance to infection. So, similarly, disseminated disease, any patient having cancer or AIDS, they are vulnerable to infection easily than the normal population. Iatrogenic. Iatrogenic means patient is under radiotherapy or chemotherapy or patient is on long-term steroids. These are the patients who have reduced resistance to infection. So basically, these are the patients where the coronavirus can take an upper hand and create problem. The risk factors for increased risk of wound infection. So the risk factors for infection, they're almost similar. Malnutrition, if the patient is obese or a patient has a lot of weight loss. And then we talk about metabolic disease, the diabetes, uremia, and jaundice, immunosuppression, cancer, the patient has AIDS, the patient is on long-term steroids, chemotherapy and radiotherapy, and colonization and translocation in the gastrointestinal tract. Now, what you have to understand is there are certain strain of bacteria which act as a normal flora in the gastrointestinal tract. And all bacteria are not bad. Some are living in harmony, in symbiosis with us, the human body. So the bacteria helps in digestion, they help to break down many food particles. So they are on normal habitat in the gastrointestinal tract. So if you are using a lot of wide spectrum antibiotics, if you are using high dose antibiotics, these bacteria will shift from the gastrointestinal tract. That means they will translocate into the portal system. And now the gastrointestinal tract is devoid of bacteria. So the reason is you get antibiotic associated diarrhea. So that is the reason why you do not want to give high dose and wide spectrum antibiotics, because it causes colonization and translocation in the gastrointestinal tract. Or perfusion. Well, when the patient is in shock, any form of shock, the peripheral perfusion is so low, the blood supply is low. So once the blood supply is low, the patient is in an increased risk for infection. And local ischemia, localized, all right? You have, the patient does not have a generalized ischemia, localized ischemia. The supply is very, very low. The blood supply to a certain area or certain viscera or certain region is low, leading to really increased risk for infection. Foreign body. Here, foreign body means you're putting in sutures or any prosthesis, or maybe you're putting in a prosthetic valves, orthopedic prosthesis. So these foreign bodies, once they are in the body will always try to reject the foreign body, because the body recognizes itself as its own or foreign. So whenever there is a foreign body, the body will try to reject it. So that will lead to increased risk of wound infection. So if the foreign body is cause infection, you may have to remove the foreign body, the prosthesis, or even clips. Okay. Poor surgical technique. Okay. Poor surgical technique is if you are not doing surgery in the correct method, or if you're not doing surgery in the wanted way, or if there's too much tissue handling, or if you leave dead space around, then you have problems. And hematoma is one of the complications of surgery or trauma. That means there is a collection of blood under the skin. Okay, can you see the slides? I'm going to the next slide.
Yes,
Yes,
sir.
sir.
Okay, factors that determine whether a wound will become infected. So what is that factor which will tell you that, okay, this wound will get infected? The virulence and dose of the infective agent. So this is very important, the type of organism or the type of the dose, all right? So if maybe one organism enters your body, it will not be able to create any problem. But if they come in millions, then your body cannot cope with all that. So you land up with infection. vascularity and health of tissue being invaded. So a certain amount of tissue that is devoid of blood supply, or if the health of the tissue is very poor, then that wound will become infected. But remember that good blood supply will always create a healthy tissue. So the chance of infection in that tissue is very low. So as I was telling you, presence of dead or foreign tissue, right? So there is local ischemia, there is infection, there is gangrene. These are all dead tissue that is there. These will become wound infected. So if you see a clean wound, you do not get a lot of dead tissue. But if you get an infected wound, a lot of dead tissue, then these wounds will definitely become infected. And the presence of antibiotics during the decisive period. Now, this is important. Let me first define what is a decisive period. A decisive period is when the acute inflammatory, humoral, and cellular processes of the human body is mobilized to reach in its defenses. Or let me just read it out. The acute inflammatory, humoral, and cellular processes takes up to 4 hours to mobilize the body's response to a breach in its defenses. Now, let me explain this. So, if anybody sustained injuries anywhere in the body, it will take at least 4 hours for all the body's defense mechanism to reach that particular spot. For that reason, before we do any surgery, during anesthesia, we'd like to give the patient prophylactic antibiotics so that the patient is protected from the any form of infection that is going to happen in the next 4 hours, because in the next 4 hours the patient is exposed to a lot of organisms. So that is why before induction, before you give anesthesia, you give a shot of prophylactic antibiotics and you start with the surgery. Now, if your surgery is more than 4 hours, we'd like to repeat the dose of the antibiotics. That is trying to prevent wound infection, basically depending on the type of surgery. So local and systemic manifestation. So finally, after talking so much about infection, we have come to the definition of infection. So it is the invasion of the organisms through tissues following the breakdown of local and systemic host defenses. Local host defenses, the systemic defenses, when there is a breakdown of the body's system, you end up with infection. Now, infection, if surgical wounds, is referred to as superficial surgical site infection. This is an infection that occurs where the surgeon has given the incision. And sepsis is another terminology, which is the systemic manifestation of documented infection. The patient has multiple trauma, the patient has burns, the patient has pancreatitis, and all the sequelae of that will lead to sepsis. In fact, sepsis is the terminal state of septicemia. And in sepsis, this may even develop SRIS, systemic inflammatory response syndrome, or multiple organ dysfunction syndrome. So these are all features of shock and infection. And lastly, they may go into multiple system organ failure. So these are just the sequelae of what an infection can happen. So if the infection is not controlled, you are really, really looking into a very serious consequence. Can you see this picture?
Yes, sir.
So what is this? Who's that? Rosmi? Oh, what is this? Anybody? Are you there? Anybody can tell me what this is? Are you here? Yes, what's that?
Sir, hematoma हो.
Yes, who's that? What's your name?
Pranab.
Huh?
Pranab.
Pranab, you've done a very good job. Have a great day. You've hit the nail right on the head. This is a traumatic hematoma.
Thank you, sir.
Hematoma is collection of blood under the skin. So this gentleman sustained muscle injuries and the perforators of the muscle bled, and he has a localized collection of blood under the skin, which is hematoma. Now, the complication of this hematoma could be this may lead into cellulitis and then subsequent abscess formation. So you have to treat hematoma conservatively. That is the treatment of hematoma. You just treat the patient conservatively, and in about a week's time, the hematoma starts to re-dissolve and there should be no problem. So this is very interesting data about the human body. The human body harbors approximately 10 to the 14 organisms. So that is a huge number of organisms that everybody has. You and I are living with it. So any infection that follows surgery now, it could be termed primary or secondary. Primary is commonly acquired or endogenous. So, and then secondary is exogenous or hospital acquired. So for that reason, we do not want to put our patients in the hospital for a very long time because they may develop secondary infection or exogenous hospital. So interestingly, the infection rate in our surgical wards, the wounds getting infected, and all this is about 5 to 10%. Now, I don't know about the other medical centers, but this is, I think, an acceptable infection rate in our hospital. And the infection rate in our operation theater is almost 5 to 7%, depending on the nature of the disease. So if the patient has acute diseases, or if the patient comes with, sometimes the patient comes with very bad injuries, then you have almost 7%. Otherwise, the normal routine cases that we do, our infection rate is less than 1 to 2%. But if these patients are very massive injuries, if the patient is in a very acute state, you can go up to 5 to 7%. So that is the infection rate in NMCTH. And over the last 14 years, we have had about 50 deaths from sepsis in our ICU. So that's about, I don't know, 3 to 4 cases, almost 3 or 4 cases every year of sepsis. Surgical causes. I'm only focusing on surgical causes of sepsis. Major and minor wound infections. Well, major infections means there is significant amount of pus formation, either spontaneous or it has to be drained. There are systemic signs like tachycardia, there is pyrexia, there is raised white count, and obviously delayed discharge from the hospital. The patient has to be in the hospital for a certain amount of time before you can discharge the patient following treatment. Now, minor infection, the pus may discharge or get infected, or just simple infected serous fluid, no excessive discomfort. The patient has no symptom or there is no delay in discharge. So you can probably send the patient home in 1 or 2 days after your treatment. देखिए जाएगा सही slides.
देखिरहेछ सर
Okay. Wound infection continues, and it presents, the wound infection presents all features of inflammation like calor, heat, rubor, redness, dolor, pain, tumor, loss of function. So this is something that you studied in the pathology. So it's the same thing. Pus, all right? So a cavity has pus. These are all dead and dying white cells that release cytokines, oxygen-free radicals, and other molecules. So there's a lot of dead and dying white cells inside the abscess cavity. Now, abscess is any collection of pus in a cavity lined by a pyogenic membrane. So the treatment of abscess is always incision and drainage because your antibiotics cannot penetrate the pyogenic membrane. So what happens inside the abscess cavity? The abscess contains hyperosmolar material. So that will draw in a lot of fluid from the outside. So now the abscess cavity gets bigger and bigger, and there's tremendous amount of pressure inside the abscess cavity. So this pressure causes the pain because, and then sometimes you have spontaneous rupture of the abscesses. You can see that the abscess has, there's so much pressure over the abscess cavity that it ruptures. Okay. And most of the abscesses takes about 7 to 9 days after surgery. So wound infection cannot be expected in 3 or 4 days. So if the patient after surgery develops fever, shrinking rise of fever, and then chills and rigor, you have to check the wound. Maybe the wound has gotten infected. So it takes about 7 to 9 days. And the treatment I told you is always incision and drainage under anesthesia. And the abscess is always very, very painful. So you have to be very, very liberal with analgesics. Can you see this picture? Can you see this picture?
Yes, sir.
Yes, sir.
So this is an abscess cavity that spontaneously ruptured, and you can see the pus draining from this infra left knee portion. All right, so you can see actually, if you can enlarge the picture, you can see a pus dripping. This is the abscess cavity where you can see a small hole, and they have debrided the wound, and the pink tissue that you see is granulation tissue. But you can see pus dribbling down the abscess cavity. So this was a very nasty abscess. Well, cellulitis and lymphangitis. Well, to tell you, define cellulitis, it's a non-suppurative invasive infection of tissues. The causative organisms are usually beta-hemolytic streptococci, staphylococci, and Clostridium perfringens. So if you look at cellulitis from outside, the skin is all inflamed, it's red, there is uniform swelling, and sometimes you get systemic signs like SRIS, chills, fever, and rigors. Lymphangitis, on the other hand, you can see painful red streaks or red lines along the affected lymphatics. And this also may develop SRIS. Both cultures are negative in both. Blood cultures are negative in both. So if you do a blood culture, excuse me, you'll not get any organisms. But the treatment is always conservative according to symptoms. So if the cellulitis does not improve with conservative treatment, the patient may land up with abscess. So for that reason, the patient has to be on antibiotics and other supportive symptomatic treatment. Can you see this picture?
Yes, sir.
Yes, this is some, you can, well, this is not a hematoma. This is actually a little bit of cellulitis, a little bit of lymphangitis. You cannot see lymphangitis, red streaks, but this is definitely cellulitis. And you can see the swollen foot. There's a lot of edema. Okay. So in cellulitis, you get redness, edema, diffuse swelling. Okay. The treatment is conservative. So if you do not treat cellulitis in time, you could land up with abscess. So bacteremia and septicemia. Bacteremia is having a lot of bacteria in the blood system. It is very common after anastomotic breakdown. Anastomosis means joining of the intestines together. Okay. So the intestine contains a lot of organisms, a lot of fecal matter, a lot of dirty fluids. So that could cause bacteremia, and it's usually transient. On the other hand, septicemia is accompanied by multi-system organ failure. So in septicemia, you have a lot of multiplying bacteria in blood, which will cause symptoms. So it's very difficult to control septicemia. And this may follow anastomostic breakdown related to the colonization and translocation of bacteria. So whenever there is a lot of problem, now if you're treating septicemia, you're giving the patient high dose antibiotics, there's always colonization and translocation of bacteria leading to infection elsewhere. So the treatment of septicemia is always conservative according to symptoms. The problem of septicemia is it develops sepsis. Well, I cannot say it develops sepsis all the time, but 80 to 90% of the septicemia patients will develop sepsis. And once sepsis develops, it's very difficult to treat the patient. Now, in regard to this, we can see a picture here. This on the left side, can you see the picture?
Yes, sir.
Yes, the one on the left side is a healthy bowel. The bowels have been resected, and the one on the right is the gangrenous bowel. So you have to resect all of this because this is not healthy bowel. You have to resect all of this, and this is a healthy bowel. And after resecting all of this, you anastomose. That means you join the bowels in 4 layers. We'll talk about 4 layers in the subsequent classes, but it has to be joined in 4 layers. All right. So this is a unhealthy bowel, and these types of anastomosis are the ones that are likely to cause septicemia or bacteremia. Now, talking about prophylactic antibiotics. So prophylactic antibiotics are given in the decisive period. We did discuss about the decisive period. So whatever has to be done, it has to be done within the 4 hours to prevent infection. And IV antibiotics at the time of intubation, I mentioned earlier, before the anesthetist intubates the patient, you give IV antibiotics. And if the surgery is you suspect unexpected contamination, if it's a very dirty surgery, or you have to put in a prosthesis because you don't want the prosthesis to be, infected, you have to repeat the dose of antibiotics after 8 hours or after 16 hours in long operations or involving prosthesis. And the choice of antibiotics would depend on the expected spectrum of the organism to be encountered. So if you're thinking that maybe this organism is prevalent in this certain area, then you have to give an antibiotic sensitive to that, right? So that you have to make a little bit of an assumption that maybe these are the organisms that are freely available there. So I would like to use these antibiotics. And as I mentioned earlier, the use of newer wide spectrum antibiotics for prophylaxis should be avoided because there is a lot of resistance to antibiotics because people are not the physicians are not using empirically and they're not using rationally. So they're using Tom, Dick, and Harry antibiotics. So they develop resistance. And once you develop resistance to newer wide spectrum antibiotics, the patient is doomed because the narrow spectrum antibiotics will not work. So it's always wise to start narrow spectrum antibiotics. And then if it does not work, if there is no sensitivity to that, you switch on to the wide spectrum antibiotics. But the use of newer wide spectrum antibiotics should be avoided. And patients with valvular heart diseases, they need prophylactic antibiotics for even simple procedures like dental extraction, or they're doing a simple procedure or under local anesthesia, they need a lot of antibiotics. These are because these are the patients who are vulnerable to infection. So let me show you a chart here. Can you see this chart or the table?
Yes, sir.
Yes, sir.
Okay. Okay, so when you are doing surgery, if the wound is clean, there is no viscous open. You're not opening up any viscera. You just incise. You're doing a laparotomy means you're opening up the abdomen. You go inside and do simple surgery. No viscera is open. The infection rate is 1 to 2%. If you do not give prophylaxis, but if you give the prophylaxis, it's the same. So you see, before prophylaxis is the same. So it doesn't really matter if you're doing clean surgery, but if you're doing a surgery where it's clean contaminated means you've now opened up the viscous. A viscera has been opened. So viscera will often definitely contain a lot of fluid and there's a lot of spillage. The infection rate is less than 10% if you are giving prophylaxis. Now, before prophylaxis, it could go up to 30% if you're doing gastric surgery. So if you're opening the stomach, the infection rate can go up to 30%, which is very high. 1/3 of your patients get infected, and biliary surgery up to 20%. So 1/5 of your patient can develop infection. Contaminated means you have open viscous with spillage or inflammatory disease. All right. So you open up the viscera and the whole of the peritoneum is filled with infected fluid. The infection rate is only 15 to 20%, but it can go up to 60% if you do not give any antibiotic prophylaxis. And dirty is when the patient is already has a hole or perforation, or if you are incising an abscess, big abscess, the infection rate before prophylaxis is 40%, and before prophylaxis 60% or more. So 6 out of 10 patients could develop infection. So then we discuss about a lot of